Today we have the legendary Dr. Lou Hart with us. We'll be talking about medical health for BIPOC communities, communities of color. We have an incredible line of show today where we're going to give you information that's going to help in lighting you and your family to have better outcomes. Dr. Lou, thank you so much for joining us today.
Oh my gosh, Ms. Shaniqua, it's so great to be with you again. I cannot wait to jump into this content and to have I hope, a very eye-opening and thought-provoking conversation today.
Same. And just asking everyone to lift this message up to your colleagues, your networks, so we can amplify this very important message. Dr. Lou, I want to jump into your bio for those that don't know you formally, and then I'd love to jump into our first question.
Let's do it.
All right, awesome. Dr. Lou Hart is the inaugural medical doctor of health equity for Yale New Haven Health Systems. The mission and YNHHS Office of Health Equity is to eliminate unjust racial and social barriers that contribute to devastating health disparities for our patients. This goal is part of a collective effort to improve the health and well-being of all patients by proactively identifying and working to eliminate institutional bias, structural racism, and social impediments to health. Dr. Hart envisions a system that is more just, resilient, data-informed, and accountable, and providing high quality, safe, and equitable care to every patient every time. By calling everyone into this collective mission and acknowledging that there is no comfort in growth in the end, he believes we are always stronger and better as we grow together. He is active clinically and continues to see patients as a pediatric hospitalist, where he is responsible for teaching medical students and resident physicians as an assistant professor of pediatrics and faculty member in the Yale School of Medicine. And then prior to joining Yale, while the director of equity, quality, and safety at NYC Health and Hospitals, which is the nation's largest integrated public health system, he founded and led the Medical Eracism initiative that focuses on abolishing the use of race-based clinical tools and algorithms that further contribute to health inequities. And in New York City Health and Hospital initial efforts, they were successful in eliminating race-based adjustments and EGFR reporting, VBAC counseling, and pediatric UTI risk assessment from their entire health system. That's incredible. And I'm also like, wow, I didn't know that. Very enlightening. Dr. Lou, you're such a trailblazer in this. So I am really excited about our discussion today, and I want to jump in to the first question.
Absolutely.
So I'd love to find out, and I know we've had talks before about your work, but medical eracism, I think that might be my first time hearing that. Can you explain to those that are listening, what is medical eracism and what does that work entail?
No, thank you so much for the question. And again, before I jump in, I definitely, you referred to me as a trailblazer, but I wouldn't be able to do anything that I do without the pioneering people who came before me, who laid the groundwork for me to have any of the opportunity. And I feel very privileged to be able to lead this work on top of the backs of so many who, laid the bricks for us to really advance this work meaningfully moving forward, passing the baton forward. And making sure that I'm cognizant that I want to make sure that the next generation of leaders has an even easier or more, a quicker chance at success than those who came before, and that we're still kind of fighting through right now. But in terms of the Medical Eracism initiative, so it was actually back when I was at New York City Health and Hospitals. This was just prior to the pandemic, and then really during the pandemic. It really came to the national, spotlight, especially in like academic journals, medical journals, how many different decision tools or like calculators, things that we could do to score a patient's risk of having a certain outcome, included race as a variable. Like somehow race was an independent, biological variable like sex or height or weight or blood pressure. It was almost like a vital sign. And that it was yes or no. You are either in this race or you're not in this race. Mm-hmm. And it really first kind of came to note when we were looking at our kidney function measurements. Like many hospitals and health systems around the country, we used a calculator that was derived in the late 1990s and then was kind of like reaffirmed in probably 2009. And when measuring someone's kidney function, it actually added points to the level of function if the person identified as Black. And so then it's kind of, so we would get two different readouts. One would say EGFR black, EGFR non-black. And like, I don't know if it's just you and me, but whenever I see black and non-black, I evoke the Jim Crow South. I evoke, institutional racism and, like separate and unequal. And unfortunately, when you kind of looked into it, that's often what it led us to. Because it was artificially boosting the kidney function for black patients, because of the research that supported that, which I to this day believe was a misunderstanding of their findings. Not that they didn't find things, but that they just misunderstood the implications of those findings. Sure. When they were doing the studies, they found that black patients were more likely to have higher levels of the protein creatinine in their blood, and that at every level of that protein in the blood, their kidney function seemed to be better. When we found a difference between two populations, we shouldn't just assume it's inherent. We should probably just say it's a disparity. It's a difference. Is it meant to be? Is it biologically innate and it has to be this way? Or might the black patients in the study have been sicker, have been living in certain communities that increase their risk of having different kidney function? Might they have had different diets? I mean, many things go into that. So, I mean, not to play stereotypes, but that's unfortunately what they did. They made a very categorical yes or no. And what that did is, when we were looking at someone, if they were white and they had a certain level, or non-black, I should say, we would say that's sickness. We need to refer you to see a kidney specialist. We need to start medications. But if the same person comes in and they were perceived as black and they had the same value, we would have actually added points. And we would have said, no, for you, that looks pretty good. Your kidneys are functioning well. We'll see you again next year. So that was kind of the canary in the coal mine, where we're like, oh my gosh, like for the past 20 years, we've been reporting out on every patient report, EGFR black, EGFR non-black. And no one has really kind of called us on this. I don't think our patients understood that this was happening. And most people in the medical community just thought it was like, well, this is science. Like this, obviously people did a lot of great research and they found this. And it wasn't until that kind of shoe dropped that we started to see like, oh my gosh, there's like 30 other algorithms across our health systems that are using race as an independent variable and treating people differently for their bone density scanning, for which type of medications we prescribe for their high blood pressure, for how we risk who we're likely to offer a vaginal birth trial after an earlier C-section. And for Black and Hispanic women, we were more likely to do a repeat C-section because that's what the calculator predicted. So, it was, I'm labeling a few there. I could spend the whole hour or 30 more minutes talking about them, but it's really the moral of the story is that we shouldn't be treating race as a biological variable when it is absolutely a politically or socially constructed idea. It's an identity that is put onto you by society that often is affirmed to you within communities, but it's something that can change over time. It's not something that's fixed, and two people from the same racial group might have nothing to do with each other. And when we look at it from a biological standpoint, the part of the world that has the most genetic diversity is Africa. So you take an East African and a West African, they are more genetically dissimilar than an Asian person and a Latin American person. I mean, like, you couldn't find more difference than anywhere else but in Africa. So to say that like one type of Black person and they all are the same, it's just bad science. And I think we're starting to realize that just because we notice a pattern in the data doesn't mean it has to be that way. We shouldn't normalize it, especially when it's in a history and a context of great unfairness and injustice. And maybe we need to understand, how did the injustice potentially produce that difference? And if we begin to crack away at that injustice, might that difference go away?
That's incredible, and completely agreed. I think it was, you broke it down so you're very articulate in how you broke it down, but it's a political social construct, and it really logically doesn't make sense that you're basing something that's politically rooted through by a biological methodology. It's not making any sense, as they would young people say, the math ain't mathin'. So I love the fact that you're championing this work, and you've made so much progress, especially during one of the most pivotal times of our world during COVID. So congratulations to you for that work. And then you mentioned there were 30 algorithms. Did you mind naming just a few more?
Well, I mean, beyond just even algorithms, like I'll show you some other places that they show up. So when someone orders an EKG, which checks the electrical rhythm in a heart, it often prints the race on the top of the film. And there was this precedent that somehow by having someone's race, you could identify different arrhythmias that were more likely to exist in certain groups. But we know, like, a broad category like Asia or Asian has so many different populations and so many different genes. So that's something that we're working to eliminate. We know that in pediatrics, we used to have And I think this one is actually pretty shocking. Some of the data supported that East Asian was a race, and that East Asian patients were at higher likelihood of having jaundice when they were first born. I think it's kind of ironic that the pejorative term for a lot of Asian people is that they have yellow skin or that they're yellow, and yet the equation reified that and said, "Oh, you're right, they're East Asian. They are at higher risk for jaundice." Was that just because people were looking at people who have a different skin tone and saying like, "Oh, yeah, this is likely to be jaundice"? Was it explained like who is East Asian? Like, are the Philippines in East Asia, or is like Western China still East Asia? What if you have your mom is Chinese, but your dad is Nigerian? Are you East Asian enough? I mean, it's just really hard to do this type of stuff at the bedside. I had mentioned a tool that predicts the likelihood of having a fracture, the FRAX calculator. It's actually validated across 73 different countries. And there's only 3 countries in the world that use race: the United States, Singapore, and I want to say Brazil. So 3 nations that have like long histories of structural discrimination. And why like Canada, France, the UK does not use a race variable. It can be done. We've just chosen to racialize a bone density screening tool. And we use it to say who's more likely to need a medication, even though in our country, African-American women are have the highest mortality and morbidity from hip fracture. It actually rates them as lower risk. Mind-blowing. So I could keep, there's an algorithm that predicts the likelihood of having a heart attack or a heart failure in the hospital. African Americans in our country carry the highest mortality. They die the most, and they have the most comorbidity. They're the sickest when they develop heart failure. And yet the calculator says when a white patient is admitted to the hospital, they need more resources because they're at higher risk. Pretty much what this means is that how can both those things happen? Pretty much what it's meaning is that a lot of the Black patients with heart failure are dying at home. So it doesn't show up in our data as an in-hospital death. So we look at it and say like, wow, no Black people die in the hospital. It must not be a problem. We must have to focus all of our resources on helping white patients. Again, it's just a misinterpretation of the data. I think the most exciting thing about the We Ask Because We Care, the Medical Eracism campaign was that it started as like a small fellowship project that like me and a few others started at New York City Health and Hospitals. And then it like got a little bit of like local acclaim in the city of New York. And then I want to talk about a real trailblazing leader, Dr. Michelle Morse, the new health equity officer at the Department of Public Health and the medical officer at the Department of Public Health and Mental Hygiene, actually turned it into a much larger coalition around citywide. So now it's called CIRCA, the Coalition to End Race in Clinical Algorithms, and it includes, I want to say, like at least like either 9 or 11 hospitals in New York City trying to coordinate the efforts to eliminate this. So it's not just one hospital at a time. So I think that, that's another, to want to talk about a trailblazing leader that definitely deserves to be on this type of show way more than me. I'm a huge, fan of hers. She's a mentor of mine. And it just speaks to what one small change can lead to a whole citywide change and how we need to obviously make this work national and even global.
That's incredible. And you're helping so many people just that have never heard this information before, the algorithms that you've mentioned, the bone density. I probably didn't get all of them.
I'll send you a list after we finish.
Please do. That would be incredible. And another way, how are you educating the public so they can make better health decisions for themselves and their families? If any educational campaigns going around.
And this is, I think, an opportunity that we still have. It's still a blind spot for us, or at least for me, in terms of how to best communicate a lot of this information to the community in a way that will, and I think there's no one way. Like, so we print newsletters and we put it in there, but like how many of our patients read those newsletters? And not everybody in our community. I mean, we're the largest provider in the state. So I would say if we have the most amount of patients of Connecticut, and all of our hospitals are in, urban centers where we have great economic and racial diversity. But I would say that most of our outreach happens through, our publishing in local papers, working with local media agencies to put it onto their websites. But again, I don't know if that's reaching everybody. It's a little bit of a sensitive subject because, healthcare in our country is so broken. And so a lot of people are unhappy with our current healthcare system. So whether it's Yale New Haven Health, or it's one of our, another health system in the state, or it's any hospital or health system in the country, people tend to be a little angry at their experience of healthcare. So then when, you're the health system that comes out and says like, not only like is healthcare broken and like sometimes you're not always happy with the amazing care that we can provide, but we've also been like treating you with racial bias for the past however many years. And we
Forever.
really, we know you might not have trusted us before, but we hope that you can trust us more now because we're telling you what we're doing.
I really am just.
So like a lot of people are like, you can't tell, you can't be so transparent because people
Mm,
will, it'll create more distrust. And I'm like, well, unless you're being transparent and honest, people are going to find out one way, and would they rather find out from us or find out from somebody else? So I think that there's like a little bit of like hesitation around this. There are some health systems in the nation that are being sued because of their use of these algorithms, like violating the Civil Rights Act, racial
sure.
discrimination in a program. So I think it's like, from a liability standpoint, there's some concerns, but I would say that, as I'm kind of half and half. I have an academic side at Yale School of Medicine where I'm free to publish everything I can in journals. My biggest concern is who's reading the journals. I'm oftentimes not even reading the journals. I know my patients aren't reading the journals. They're behind paywalls. You have to pay huge amounts of money to get this stuff. So it's really an elitist approach that I think is not effective. Even putting it on the New York Times, I think it needs to go on social media. And that's why I have a huge colleague and friend, Joel Burville, who is really leading the change and using TikTok as an amplifying message to really get a lot of this race-based, the pulse oximeter that looks at the blood oxygen is different on black skin tones than non. He's getting a lot of this information out and has hundreds of thousands of followers. So he's doing a lot of great medical education using social media. I think that's a more effective way to at least get the next generation, but to also start to have, what a kid learns will often tell their parents, and then that gets around to the whole family.
That's incredible. And I love how you broke it down. And did you say his name was George Burgle?
Joel Burville, and I can send you his contact information, or I can even just put some of his info. But he is, if you just looked up Joel and then last name Bervell, he is again another pioneering leader. He's actually a medical student. He might be finishing up his medical schooling this year or next out in Washington, and will be starting his residency training. But talk about taking on the world as he's a busy student.
That's awesome. Kudos to you, Joel, for all the work that you're doing. I'd love to definitely reach out and see what he's doing. But I think it requires a strategy very similar to what he's doing. We have to reach our communities, reach out to them where they are. We got to engage community-based organizations and social workers to lead the charge, because you're the ones in the community that our families are most likely to go to and trust and confide in. So there is a way to leverage that. So I think it needs to be sponsored. We need sponsorship behind this type of work. So that's a really interesting project, future project that we may be able to potentially explore as social workers.
Yeah.
Yeah. Well, speaking of, you talked about your the student, the medical student, Joel, who's leading the charge on TikTok. One of the things I would love to learn more about is how you've been seeing institutional bias show up in Yale School of Medicine or just schools of medicine, and what are some ways that your teaching has been breaking those cycles of institutional bias? What are some things that you've been working on and doing in that area?
So I would say that I think the medical schools are doing are in a different position to advance a lot of this dialogue quicker than health systems, just given like the medical students are the customers, for lack of a better term. And they tend to be a younger demographic that have grown up in a world with the internet, that have grown up in a multiracial society, that understand that like the ways of the 1960s are probably not going to be the ways of the 2060s. So they're actually demanding this in their curriculum. They're saying you can't just tell me to memorize this statistic that black people's skin is thicker anymore. That's nonsense. Where did that come from? Show me the evidence. So they have I don't know if that's just a generational thing, if this is, Gen Z millennials just tend to be a little bit more like, I don't believe in tradition or dogma. I'm not going to church until you tell me until I can experience it. I'm not just going to take your word on it. I'm going to verify it. And so I think that there's, in some ways that can create conflict, but in many ways that can create a lot of opportunity and a lot of growth. So I think, from at least our medical school, I know that health equity is not a one-time class. It is a thread throughout the 4 years. So in every block, you're talking about pulmonology and the lungs. You're talking about cardiology and the heart. They're going to bring up a case study around a drug that has FDA approval for the treatment of heart failure in black people. It's not indicated to anybody else, but black people. And I remember it was FDA approved in 2005. And I remember there was an older black woman in the back of the focus group. And she says, I appreciate what you're trying to do to help the community, but I want the drug that the white people are getting. And she grew up in a time where, black people were probably getting special stuff. We saw in Tuskegee special treatments. No one wants that, given this country's history. So I just think that, like, Whereas I was only in medical school. When did I finish medical school? In the early 2010s. I was kind of told to accept dogma a little bit more. And I went to a very progressive medical school, the University of California, San Diego. This is a medical school that really taught us about social drivers of health and barriers that different people, we had to do field trips where we actually went into communities with local communities leaders and actually toured and walked around. It unfortunately still felt like tourism, which I think was a little bit, off-putting. But for many people, this is their first time going to certain parts of their city and seeing how differently people are living and understanding, like, when I tell my patient to stop eating all that fried food and then I go into that community and that's all that's there, how can I expect my patient to do any differently when they had to take a couple buses to get home and they have 2 different jobs they're working and have kids that they have to do homework with at night? So, I think it just was eye-opening a little bit, but that's not enough. Like, we need to actually be doing, a whole lot more in this. But I think medical students or medical schools are in a much better position than a lot of times hospitals are, because hospitals are very traditional and they have, a lot of, leadership structures and bureaucracy that make change a little bit harder. You can't just change the curriculum in a year. In a medical school, you can, but in a hospital system, there's so many ways of doing. So I would say that, institutional bias in terms of the education, a lot better. An example of institutional bias that we saw in our healthcare system, or at least in our hospital system, which that is not unique. I've worked in a few different hospital systems, and it is not unique to the one. We just have data to prove it that was happening at ours, was the use of newborn urine toxicology, or drug testing babies if their mothers or their pregnant, their parents were using substances during the pregnancy. It's a whole lot of backstory, and I'll try to be pretty brief with it. But the idea is that, like, substance use disorder is a huge epidemic in our country, and sadly, it affects all of us equally, regardless of our race, regardless of our socioeconomic status. But because of bias and perceptions in our country, there are certain people who are, the occasional, pill taker to relax versus someone's a cannabis user and they need to be, vilified. And when we are deciding who to screen for substance use disorder, we bring our own biases, what we see on TV, who looks like a drug user and who looks like someone who maybe just needs a little bit of help and just needs a little bit of support for their mental health disorder. And unfortunately, a lot of that bias around people who were, maybe insured by Medicaid, who had lower incomes, or people who were who appeared African American or were Black identifying, in our practice, it seemed we're more likely to screen. So when we looked at our data comparing Black babies to white babies, Black babies were almost 2.5 times more likely to be tested. We then looked at the results of the testing, and we found that it was actually the white babies that were over 2 times more likely to be positive. So white kids were way more likely to be positive, and we were under testing them, and we were over testing African American babies because of our bias. And then so we partnered with the state, and we said, like, what is the statewide prevalence of substance use disorder during pregnancy? And it was actually the same. It was around somewhere between 10 to 20%, which is a lot of pregnancies. That's 1 in 10 women or pregnant persons are suffering with substance use disorder. And at the 20% level was just any use. And at the 10% level was like heavy use of whether that's alcohol or cannabis or opioids or even cigarettes. So again, these are things that we know are not beneficial to baby, but we know oftentimes represent an untreated mental health condition that parent's going through. And as opposed to criminalizing, we should be normalizing that life is hard and that we all go through things, and that some people reach out for substances because they don't have other support systems, and we need to support families through that to keep families together. But in our process, once a baby was tested and positive, it created an automatic referral to the state, and then that led to a DCF, or a Department of Children and Families investigation, that more times than not, that drug test was used as evidence to substantiate harm. And so unfortunately, we were splitting up families unbeknownst to us. And as a clinician, as a pediatrician who takes care of babies in the hospital, whether the test is positive or negative, I'm going to treat you the same anyways. If I have a concern that there was substance exposure, I'm going to keep you in the hospital for a couple extra days and make sure you're doing well. And if you start showing signs of withdrawal, I'm going to start treating you for those signs. And a lot of them are not using medicines anymore. It's eat, sleep, console. Keep the baby cozy. Keep the baby with his mother or his parent, or her parent. Keep it quiet, it dark. Anything that if anybody's ever had a little too much to drink, the next day you don't feel that good. Those are the same types of things that you would want to keep. A nice, calm environment for the baby to get better. Keep breastfeeding so that you can wean off whatever that substance was. Like, there's certain things that are beneficial that are not medicines. And whether I have a positive test or not, it doesn't change how I care for the baby. But having that positive test in the chart biases the care for the next person that comes and sees the patient, and might actually have an impact on the criminal justice system or the child welfare system, which I do not work for the child welfare system. I am not an agent of the criminal justice system. I'm your doctor. I work for you. So I want to make sure that I'm not causing downstream harm, real harm, by doing a test that actually doesn't even help me care for you better. So ever since we've had this data, we implemented a process. The disparity is gone, and our testing rate went from about 5% to less than a tenth of a percent. I mean, we don't test really anybody nowadays. We just treat all of our babies who show symptoms like they have withdrawal. So there's no more disparity, and the care is better for all of our patients.
How did that make
patients are beginning to trust us a little bit more, so we don't even need to test them. They'll just tell us. If we just say, "Trust me, I'm not going to refer you out. I just want to know so that I can care for you better." Oh wait, you're trying to help me? Yes, that's what it should have been my job this whole time.
Trap you and that's really been the experience of a lot of our communities of color, people of color, and why there's so much mistrust. It's rooted in some real evidence here, factual things that have happened, that have taken place, that have caused a tear in trust. It's been so difficult to rebuild, but it's so, I don't know the word for it, but it breaks my heart to hear that this practice was in place. And to think about what happens, someone that's worked in child welfare system on a state and county level for over 10 years, and thinking of the impact this has on families. When they leave out of the hospital, what happens? I know how vicious the family court system could be. I could remember having a colleague who was a social worker who was going through family court, and she almost lost her mind. She checked herself in a hospital after a family court case. An incredible mom, right? But in a licensed social worker, but she was going through this challenge with her child's father, and she ended up in an institution, mental institution. Because so are you understanding how vicious the family court system could be? How are we supporting and restoring families when we're trapping them and weaponizing what's supposed to help heal them in a place that's supposed to be safe, like a hospital?
You said that perfectly. And the sad thing is that it's not just something. I wish it was only our one hospital, and when we got rid of it now. But I have worked at a few other hospitals, and I know this is an issue from colleagues around the nation. So I think what we were able to successfully do here is that we partnered with in New York City, it's called ACR. In New York, it's called ACS, the Administration for Child Services. In Connecticut, it's called the Department of Child and Children and Families, DCF. So we actually partnered with DCF, and they told us, we don't need a positive test. We don't even need a test. If you have concern for substance use disorder, we can give you all the resources you need. We can help you set up a safe plan of care for the family. We actually don't need the test. So we thought they needed it, and they thought we wanted it. So there was this whole misunderstanding. So once we had a partnership with them, and we're actually going to be writing a paper together on this, I think that's like, if we really talk about groundwater problems, we can't just fix healthcare disparities alone. We can't just fix the child and welfare system alone. We need to align, get on the same page, because all of our systems connect. So when you have two big sectors of the economy coming together to tackle a problem, it's going to have a big impact on our entire state, which I'm just so proud to have played a small role in impacting.
That's incredible. And all we had to do was get these two entities to talk to each other because we're serving the same families,
same people,
same goal in mind. And all we had to do was come together and talk. This has been such an insightful talk, and we're wrapping up. We're coming to the end, but I wanted to give you an opportunity to talk about the YNHHS approach and initiative that you and your colleagues have been working on. What does this mean, and what's your goal and your vision for this initiative?
All right, so this is a perfect question. It's going to tee me up well to talk about Yale New Haven Health, the YNHHS, Yale New Haven Health Systems. We Ask Because We Care campaign. And this is a system-wide, and since our system is statewide, it's going to be a statewide, really public relations and educational campaign for our patients and our staff to understand why we ask our patients to share their demographic information with us. For the longest time, we've kind of done this as a part of registration, and for some people it came as off-putting. Some of our patients were saying, why? I'm human. Just treat me like a human. Some people are saying, why do you need to know this information? Is this an immigration question? Some people saying, is this going to impact my care? Are you going to treat me differently because of this? Sure. And so I think for too long, we just haven't done a good enough job educating our patients why we're asking for this information. Was it because the state asked us to, or some regulatory body? And at our health system, we want to be very explicit about why we ask this question. We ask because we care. And so this is modeled after a campaign that has been done at many other health systems over the past 20 years, came out of research by the Robert Wood Johnson Foundation. And it creates like a easy to understand kind of verbiage around this. And at our health system, without this information, we cannot identify disparities. So if patients aren't sharing with us what makes them unique, what makes them special, they're not sharing with us their personal characteristics that might, unfortunately, in this country, result in them being treated differently, then I can't prove in the data that they are being treated differently. People can say I had a terrible experience, but I'll have no data to back it up. So I won't even know, am I changing it by trying to educate staff? If I create a new process, did it make it better or worse? But when people share their data with us, it allows us to, in the background, not change the care that they're receiving at the bedside, but make sure that no one's care is changed because of this. So we want to be able to ensure that that quality or safety does not vary across personal characteristics. So if we see a pattern that, like we did, Black babies are being overtested, well, now I can ask a better question. Why are we testing babies? Let me reach out to DCF. But if we didn't have the information on the race of the babies, we wouldn't have known. We would have just been looking at the average and saying, like, I don't know why we test babies, but, you know, I guess it's a 50-50 test. It doesn't seem to be hurting any one person. We probably shouldn't do it anyways. But when we noticed that glaring disparity, it really helped galvanize and build a coalition around saying, like, none of us signed up to hurt families like this, especially in a way that seems very biased, that none of us wanted to do, but we were all contributing to in our complicit, just following of the practice. So I would say we ask because we care, again, and it's going to be, you're over the next year, social media, print. I'm on an NBC commercial. There's an ABC commercial that my colleague's filming, radio. I already talked about print media. There's going to be posters across all of our hospitals. We've expanded the list of nationalities or countries or ethnic backgrounds that people can pick from, the traditional 5 census categories to over 200 different, ancestral backgrounds that people can share with us so that we can, again, make sure that no one is being treated differently because of the information they share. But if people don't share with us information, then we don't know what's happening at the bedside. We assume the best from our staff, but we know that our hospital and our health system is just a microcosm of the nation. And we know that there's problems in our country. So it'd be naive to assume that those problems don't exist in our backyard. But with the data, we can measure those problems, the disparities, and we can begin to eliminate them. But without it, we'll never have a fighting chance.
That's it. That's so groundbreaking. I think the misconception for many people is if I give you my data, you'll use it against me.
You'll use it against me.
You give me your data because I'm using it for you. So
make sure no one is going to use it against you.
That one word, against to for, it can really change the trajectory of the way that we do care. So that's incredible. And I love the fact that you have over 200 ancestral backgrounds. That's great. How can people get involved in this work and the work that you're doing? If there is any way to support your work, how would people reach out and get involved?
That's the best question in the world. So I would say, across. So the cool thing about the We Ask Because We Care campaign is that we're putting all of our material. It took us over 9 months to build multiple working groups, to make new FAQ documents, to make a training, not only tip sheets, but an online module, to get a lot of the, different posters and we're going to put that all on our website for anybody to utilize. So you can just take off the Yale logo and put your clinic's logo on, your hospital's logo. So, we're trying to be as generous, just like many other health systems are generous with us. So if you're ever willing to launch your own type of demographic information campaign within your own setting, we would be happy to share everything that we have and some of our lessons learned. The same thing with the Medical Eracism initiative. I think whenever I've had success getting rid of an algorithm in a department that's not pediatrics, not my own, it really helped when I had a champion who was from that department who could help rally some of the, for lack of a better term, troops on the ground, and really start to get people an understanding of this. So if that's a section that you work in, try to find some individuals in that section or that department that might have some, I'll give you the list and then people can see, hey, I work in cardiology, or hey, I support women's and children's services and this happens. Let me ask one of my nurses or my physician colleagues or other social workers, do we do this here? And then we can kind of spread this medical eracism type initiative, again, from just one site to multiple different sites. I think that would be huge. And then the other way would just be to kind of, I see it on the chat or on the screen, but just follow me on LinkedIn. I'm always trying to put articles, always trying to put ideas, how we screen our patients for social drivers of health and what interventions we're doing, making sure that all of our patients leave the hospital with the medications in their hand, a meds to beds initiatives. There's little things that we can do. And there's so much that I can learn from you all and everybody on this call's experience out there. We only grow stronger when we're together. And I just think it's so important that we keep these open lines of communication. But in terms of, our local campaign, obviously reposting anything we put on social media. If you see We Ask Because We Care, we would love a share because we're trying to get this information out there. And the only way we can build back trust is with transparency. And that's going to help keep us accountable because our community is going to expect more of us. They're not just going to say, that's the bad stuff that always happens there, I'm not even going to care anymore. That learned helplessness is the end of any progress. We need to make sure that people demand more of us and ask more of us and advocate for themselves in a system that has not treated everybody well or equally. So it's important that we rebuild back that confidence that what you say matters and that I'm here to serve you and that we're all, our destinies are linked. What hurts you will eventually come back and hurt me. So it's much better off that we just break bread together and try to rebuild this together even stronger.
That's incredible. Thank you so much for that, Dr. Liu. So that was a number of ways to support Dr. Liu's work. The Medical Eracism work, you can support that. Please follow him at Dr. Liu Hart on LinkedIn. He's sharing great resources for you, for your communities that you can reshare out to your networks as well. You mentioned the potential of launching your own demographic campaign. I think that's huge. I'd love to see some of these campaigns in New York City happening. So I'm gonna have to reach out to the mentor. You said, Dr. Melissa?
Oh, Michelle Morse.
Michelle. That was with the M. So Dr. Michelle Morris, definitely would love to follow her work, reach out to her. And I think the thing that's been just in the back of my mind as you've been speaking the whole time is this is a social justice issue. And so I believe that social workers should be holding up the arms of the doctors in this work and standing in partnership because this informs the way our communities are living. This informs their quality of life, how long they're going to live. So this is real work and I truly believe in it. So I would love to learn. I know we've done like a talk or two with NASW. I'd love to revisit for 2024 some ways that we could potentially support the work of you, Dr. Liu, and bring that work into the New York City area.
Oh my gosh. And I couldn't agree more with you that since this is a societal issue that is mostly created by social systems, the idea that we shouldn't have social workers be the tip of the spear, be at the forefront of this is just so naive. Because if you look at the past history, when you leave it to doctors, we try to make everything sterile into a biological, scientific experiment. And that's not how humans live. So it's just so out of touch with reality. And then we start drawing false conclusions like, oh, we found a difference between black and white people. And we had a couple Asian and a couple Hispanic people. So let's just call all of these non-black and all of these black, and we'll treat them differently because that's what the data shows. But without the context of a very unfair country that many social workers could speak to, that your zip code matters more than your genetic code, without that type of context, either a history or a social scientist like social workers on the call or at the research, then we will just struggle and we'll continue to draw false conclusions. So as a point, I try to make sure that any kind of quality improvement project I'm doing has a social worker, has a nurse, and has a physician at the table. Because just having 3 doctors together, probably 2 of us are not needed because we had the same training. So it's just very, trying to be very purposeful. And I just want to highlight the brilliant work that so many of the social workers that I've had the privilege of working with. I've learned so much from them as a physician, and it guides me to deliver better care going forward. And I want that to be true for every social worker who's on this call right now.
That's incredible. You have the heart of a social worker, Dr. Liu Hart. So when you're speaking, your passion, the love for what you do is so evident. It's so strong. So thank you for supporting social workers in your work. And again, to the social workers that are watching, please follow Dr. Liu Hart and get involved. Find out ways that you can support him. I'm particularly interested in that demographic campaign that We Ask Because We Care. I think I got that right.
Yeah.
I'm particularly interested in that. So I'll talk to you about that. But it's been a pleasure, Dr. Hart. Is there any last words that you want to leave with families or those that are looking for ways to improve their health?
Yeah, I think it really just comes down to again, a lot of the distrust or mistrust that exists in the healthcare system is rightfully earned. We deserve it. We've earned it. I'm inheriting this system as someone who, I wasn't around in the 1960s. I was born in the 80s. So I've been a part of it. But I inherited a house, that medical system, that has leaky pipes. And I could say, I didn't, build the house. I didn't cause these leaky pipes. It's not my problem. I didn't cause it. So I'm not going to do anything about it. But at the end of the day, those leaky pipes are going to hurt my foundation. And yes, I inherited this home, but eventually it's going to cause that home to crumble. So whether I created the problems or not, I still have a responsibility to improve the thing that I inherited so that I can give it better to the next generation. So I think for many people who are like, my family didn't own slaves, or I didn't discriminate against people because they were from a different country. It's like, but this is the context in which we operate in. So what are we going to do about it moving forward? Looking to the past helps us understand our history so that we don't have to repeat it. But at the end of the day, we're all in this together. And if we stop focusing on individual bad apples and start really understanding that like we're all part of this, and it's all of our when things go well, it's all of our responsibility and all of our success, and when things go bad, it's all of our responsibility to improve it. So I just would say, stay vocal, stay proud, stay loud. Good trouble is going to lead us to good answers. And just question dogma. Just because you've been doing something for the same way doesn't mean it's the best way, doesn't mean it's the right thing. The only way to grow is to try new things. And when you start noticing that, especially something you've been doing for a long time isn't really producing the outcomes that you want, then maybe it's time to have a better understanding of why you're doing that in the first place. And often when you understand that history of why things are the way they are, you realize like it doesn't really make much sense, and maybe it's about time that we change how we do things. So I would definitely just stay hungry and stay questioning of tradition, because either a lot of tradition is great, but until we can test it, that's what science is. We take a science experiment, we find a conclusion, and then we keep testing new ones to see if that conclusion still holds. We almost need to take that approach at life. So with the medical distrust and mistrust, we just need to be transparent. We need to own our reality, own the fact that this is a real feeling, and start to make better partnerships to understand, hey, how can I share some of the power that we have as a big health system with our community members, and how might you be able to hold us better accountable and have higher expectations of us than just the low expectations of what we delivered in the past, because enough's enough.
That's right. Higher expectations. We have to keep on holding our medical professionals accountable, and I realize that we deserve quality care. And you are really the advocate and the doctor in this work, I'm sure, amongst many others, some of which you've already shared. So I am very hopeful. I'm always hopeful when I hear people like you that's owning their space proudly and unapologetically in the world, and helping to move our communities forward. So thank you for the work that you do, Dr. Lou. Thank you for leading the charge. To congratulations to you and your colleagues in advance on that launch November 20th. I know that's going to go incredible. I'll be looking out for your work. We'll be sharing things on our end as well, but we appreciate you. You're a family. We've adopted you into social work.
Yes,
so
yes.
so
Thank you. I'm so grateful and I'm so thankful to have our relationship, to have this opportunity to work with IRAs and just really be a part of this positive social movement and positive change. You have no idea the privilege that I feel to have this opportunity to share this time with you. So I'm so thankful, and I'm your biggest fan. So anytime, I'm always available.
Thank you, Dr. Lowe. We appreciate that. Thank you so much. We want to thank all of you for watching and for tuning in to today's shows. Please again, Dr. Lou Hart, spelled out on the screen. You can follow his work on LinkedIn and you can get involved. We want to make sure that we expand our reach. So please do us a favor and amplify this message. Repost if you can, or share it out to a colleague, a family member, or someone that you believe can benefit from this work. Also, remember that every Friday we have new episodes released for our Elevate podcast. Tomorrow we have an incredible conversation prepared and designed just for you. So go ahead and subscribe if you haven't already on all major platforms: Spotify, Apple Podcasts, iHeartRadio, or wherever you listen. Tomorrow, again, we'll have our entrepreneurship think tank in New York City at the Morgan Stanley headquarters, where we'll be convening together and teaching our kids how to start and elevate their businesses. So registration closes today. It is free. We'll be serving food and refreshments to our kids. So please go ahead and register. Again, thank you all so much. Stay tuned. We'll see you next week. Thank you, Dr. Lowe.